A very good evening to one and all present with us today. I am Arpita, the moderator for today's session from the IGCP group. The topic that we are going to cover today is updates on SGLT2 inhibitors and GLP-1 receptor agonist. So, the topic mainly focuses on the latest advancement in the treatment of type 2 diabetes with SGLT2 inhibitors and GLP-1 receptor agonists. Recent studies continue to highlight the benefits of SGLT2 inhibitors in not only controlling blood sugar levels but also in reducing the risk of heart failure and kidney diseases complication among diabetes patients. Similarly, GLP-1 receptor agonists have shown remarkably efficacy in managing blood sugar levels and promoting weight loss. Now, to address this very critical topic, we have with us none other than Dr. Abhuday Sharma sir. Abhuday Verma sir. He is a consulting endocrinologist and diabetologist specialty. He is a specialist in diabetes disease treatment, thyroid treatment, obesity and hormonal disorder problems at he face he is practicing currently at the Seva Center in Indore. He has done DNB medical specialty training from Hyderabad and later at AIMS New Delhi. So with this very brief introduction of sir, now I would request him to please start with the session for today. Over to you, sir.
Thank you, Ms. Arpita, for the kind words and good evening, dear friends. So today, as Ms. Arpita has highlighted about the SGLT2 inhibitors and the DPP4 inhibitors, we know these two class of drugs are now available in tablet forms also, especially when I talk about the GLP-1 RAs. And we know that these drugs are very helpful not only in controlling blood sugar levels, but they control it very well without causing hypoglycemia and some extra added benefits like weight loss, kidney protection, and cardio protection also. So today I would be talking about some of these drugs in brief and some of the newer anti-diabetic agents also, which will include insulin also, so that we should know that what is the present scenario, and in another couple of years which added benefit or added extra advantageous anti-diabetic agents we would be having in future. So I'll first start with insulin. So without insulin therapy, we all know it is difficult to manage any case of diabetes or hyperglycemia. So this is icodec. This is a long-acting once-weekly subcutaneous injection. And here there are some structural changes made in the insulin A and B chain, where after subcutaneous injection, this icodec monomers, they bind to the albumin to form an inactive depot. And then when we give each weekly injection, a steady state of insulin, which is bound to albumin, is reached in 3 to 4 weeks. And then we get a slow, continuous release of this icodec insulin, which sugar control throughout the week. And this is the indication. It's a basal insulin for type 1 diabetes and type 2 diabetes mellitus. So we have once daily basal insulin. Now we, in couple of months, we would be getting a once weekly insulin. And these are various trials done with this once weekly insulin. The onwards 3 trial in insulin naive patients with type 2 diabetes mellitus, where it showed similar HbA1c reduction versus insulin degludec, which is a second generation newer basal analog, and there were no differences in hypoglycemia. Then onwards 4 trial was done, where again it showed similar efficacy in reducing HbA1c compared to insulin glargine. Onward 5 showed a superior reduction of HbA1c than insulin degludec and glargine. Onward 6 was done in type 1 diabetic patients, which again had similar efficacy compared to once daily degludec with no significant hyperglycemias. So here the starting dose of this once weekly insulin is 70 units per week. This may look like a shocking figure, but if you see, we usually start any basal insulin with 10 units per day. So if you multiply it by 7, it becomes obviously 70. So 70 units per week, and then adjusted weekly to achieve a breakfast target of whatever we want, 100 for our patient. Then I'll talk about some oral insulin. Again, this long-acting basal insulin analog 338, along with some GI permeation enhancement technology, I will in detail, they showed similar HbA1c reduction compared to glargine in type 2 diabetes mellitus. The starting dose is 2700 nanomoles, maximum 16,200 nanomoles can be given based on the fasting blood sugar levels. It is taken in morning fasting state and 1 hour before the food. Some adverse events are obviously mild hypoglycemia and GI side effects. So these are two major. Icodec, in fact, we would be getting very soon in market, but oral, yes, it may take some time because it is still in phase 2 trial. Then we have another, a slightly different molecule, the finrenone, which is a non-steroidal mineralocorticoid antagonist with highly selectivity, which downregulates the renal pro-inflammatory and pro-fibrotic gene, and it is indicated in diabetic kidney disease and in heart failure patients with reduced ejection fraction. If eGFR is more than 60, 20 mg OD. If eGFR is between 25 to 60, 10 mg OD. So this drug basically reduces or slows down the kidney dysfunction which happens in our diabetic patients, and studies have shown that it can in fact reverse the microalbuminuria, or it can bring the macroalbuminuria to microalbuminuria also. Some adverse effects, yes, we should take care of hyperkalemia, hypotension, and hyponatremia. Now coming to, as we were talking about, the SGLT2 inhibitors. So this is this dorzagliatin, which is a dual acting oral bioavailable glucokinase activator, which enhances the glucokinase activity in a glucose dependent manner. So it improves the glucose stimulated insulin secretion and demonstrates effects on glycemic control. And here this drug was given to patients who were drug naive with type 2 diabetes mellitus along with placebo, and the incidences of adverse events were similar to placebo. There were no hypoglycemia, there were no drug related adverse events, and the blood sugar levels after week 24 dropped to almost 1.07% in the dorzagliatin group versus only zero point 0.5 in placebo. So this drug, again a very good drug where insulin secretion is in a glucose dependent manner, how we see in the case of DPP4 inhibitors also. And here you can see these are the endpoints. I won't go in detail, but yes, significant HbA1c control over 22 weeks without hypoglycemia and without any drug-to-drug interaction. Then we have again this molecule which is there in market from past couple of years, imeglimin. It improves the glucose stimulated insulin secretion. So again, only when glucose increases, this insulin is secreted. Along with this, it improves the insulin resistance at the level of skeletal and muscle and liver levels. And at cellular level also, it has extra added benefit because it improves the mitochondrial bioenergetics. It has shown in various studies, data are less, but yes, studies have shown that it prevents endothelial cell death and end organ production can be seen in few of the studies. So you can see here again, this is a good class of drug, easily available now, and it has got benefits in improving the insulin resistance and improving the mitochondrial bioenergetics also. Can be given with eGFR 15 up to 500 mg once daily, and GI side effects are milder than metformin because it has got some similarity of action with metformin, so they have compared it with metformin. Can be given to patients who want benefits of metformin but they don't tolerate metformin. So GI side effects are there, but they are lesser than metformin. So we can use this in place of metformin, or if metformin we don't want to increase the dose but to improve the benefits, we can add this imeglimin drug to our patients. Then we have oral semaglutide, which we are talking today, the GLP-1 RAs, and we know what are the benefits of GLP-1 RA. So they don't only improve the hyperglycemia without causing hypoglycemia, they have benefit in reducing weight loss also significantly and improvement in cardiac parameters also, especially in patients who are at high risk of ASCVD or who have a history of atherosclerotic cardiovascular disease. And this is now in our various guidelines or algorithms where we want not only good sugar control, but we want a better safety profile or added benefits with these class of drug. That's why in our recent ADA or AAC type 2 diabetes management algorithms, they say after metformin start a SGLT2 inhibitor or a GLP-1 RA. GLP-1 RA earlier was available as an injectable, which was a barrier for its use, but now oral semaglutide is available, and here with semaglutide the permeability enhancer SNAC is added at C18 fatty chain, and it can and it should be given in all diabetic patients with obesity who have risk of hypoglycemia, who have high CV risk, or who have renal or hepatic dysfunction. So in all these indications where other drugs are not suitable for patient, and if they don't want to take insulin therapy, we can start this oral semaglutide, which has got significant HbA1c reduction along with weight loss. The dosage are 3 mg, 7 mg, 14 mg once daily in fasting state with almost 100 to 120 ml of water. And after that, the patient has to move around. They cannot sleep or sit. They should do some activities for proper action of this drug. And here you can see, I won't go in detail, but yes, compared to other GLP-1 RAs like exenatide, lixisenatide, even dulaglutide, albiglutide, and semaglutide, subcutaneous injection, oral semaglutide. You can see here the HbA1c change or control is quite significant, and the weight loss is also quite significant with the oral semaglutide. So these are some of the adverse effects. We have this Trulicity once weekly GLP-1 RA also available, but this is injectable. The adverse effects of these GLP-1 RAs, we all know, are nausea, vomiting, and constipation. And in few cases, we may get pancreatitis or medullary thyroid carcinoma, which is quite rare. Then we come to this newer, again, not yet launched, but oral GLP-1 receptor agonist or for glipron for adults with obesity, and it is a potent partial agonist of GLP-1 receptor that has a greater effect on cyclic AMP signaling than on beta-arrestin recruitment. So this should be given in patients for weight management and treatment of type 2 diabetic mellitus, and this is a once weekly administration. These are the primary and secondary endpoints with various doses: 12 mg, 24 mg, 16 mg, and 45 mg. You can see the baseline body weight good to the tune of about 8 to 12 kg weight loss. Secondary changes, again, body weight are quite significant when we see at 26 and 16 weeks. Then again, this is another new class of GLP-1 RA along with the GIPR, another incretin hormone. So this is twin cretin, and again this would be very shortly available in market. It is again indicated in obese type 2 diabetic mellitus patient or even for treatment of obesity also. And this is again 5 mg, 10 mg, and 15 mg subcutaneous weekly. And we can see here these are the trials with this. Tirzepatide surpass 1, HbA1c reduction significant, weight loss also significant, again surpass 2 also, surpass 3 also, same compared to semaglutide and degludec. This tirzepatide showed a better HbA1c reduction and a better weight loss because it has got two different types of incretin hormones. Then we have other drugs in the pipeline. This is retatrutide, which is a triple. So this is again more a GLP-1, GIP, and a glucagon triple agonist. Again for type 2 diabetic patients with obesity. Then we have another GLP-1 receptor antagonist, avexitide. It is in phase 2 prevent trial post-bariatric surgery hypoglycemia patients, where along with weight reduction, sugar control, hypoglycemias were reduced in patients who had a bariatric surgery. Then we have this long-acting analog, the cagrilintide, which is an agonist activity on calcitonin and amylin receptor. And again, it has shown to improve the HbA1c and the weight loss. So thank you. This was my short introduction about the latest insulin the GLP-1 RAs and the SGLT2 which would be shortly available in market.
Thank you, sir. Thank you so much. It was indeed a very short but a very crisp description, I would say, of the topic. And so, meanwhile, I have started receiving a few questions.
Yes, please.
Let me just check one, sir.
Yes, please. Yes, please.
Yeah. Sir, the first question is on combination therapy. So, the question is, what is the current evidence supporting the use of combination therapy with SGLT2 and GLP-1 receptors? And is there any new insights on their synergic effects or the potential risk that can happen?
Yes, very good question. Yes, definitely. Both the drugs can be used simultaneously. It will definitely have synergistic effects. As far as I know, the side effect profile of both these drugs are quite good. These drugs are quite safe, can be used in brittle diabetic patients, can be used in elderlies also up to 75 years of age, and can be given in patients with heart failure, renal dysfunction up to EGFR of 20, moderate hepatic dysfunction also. So, with seeing the added benefit of GLP-1 RA and the SGLT2 inhibitors, good sugar control with weight loss without hypoglycemia, and then these various conditions where a lot of drugs are avoided, we can use this class of drug not only for sugar control but to give extra added benefit also. So I think these combination are there in the guidelines. The guidelines, they say after metformin add a GLP-1 or SGLT2 inhibitor, or if required we can add both also.
Right, sir. Thank you so much. Next question we have received that is on weight management. In a obese patient with type 2 diabetes, how do the weight loss effect of GLP-1 receptor compared to that of SGLT2 inhibitor?
Yes, very good question. But yes, I would clarify that the weight loss with SGLT2 inhibitor is good initially, but after a certain time, the weight loss plateaus down. You know, yes, initially we get good benefit with the SGLT2 inhibitors, but the GLP-1 hormones, as you have seen in my slides, that we have in pipeline, lot of GLP-1 hormones coming along with other incretin hormones also, like twin cretins or even triple combination also coming, which have shown far superior weight reduction compared to any SGLT2 inhibitor. So I think when we want a weight loss, significant weight loss in our type 2 diabetic patient with severe risk factors, we should choose a GLP-1 RA. And when we have a slightly obese patient with more of heart failure or renal problems, we may choose after metformin a SGLT2 inhibitor. But for weight loss, I would say data, they suggest GLP-1 RA is better than the SGLT2 inhibitors.
Right, sir. Thank you. Thank you so much. There's another query, but I think sir has already covered it. Still, I would just like to read it out once. How do the latest studies compare the efficacy and safety profiles of SGLT2 inhibitors and GLP-1 receptor agonists in managing type 2 diabetes?
So
So,
I
would you
would
like to
say,
just give a bit?
yes, very briefly, I would just say that these drugs have shown a far superior efficacy and a very good safety profile in most of our uh, type 2 diabetic patients, whether it's a kidney related problem, a heart related problem or hepatic dysfunction. So these drugs are quite safe to use.
Right, sir. Thank you so much. And sir, yeah, no more questions are there from the audiences. So,
Thank
with
you.
that note, sir, yeah. Sir, thank you so much for joining in and for putting your insightful thoughts into the session. And yes, I would also like to thank all the attendees for attending the session, for giving their precious questions, and yes, making it a successful one. So, thank you, sir. Thank you so much for
Thank
giving your time. Thank you.
thank you. Thank you, Med Talks, IJCP, and thank you, dear friends. Take care. Bye bye.
Thank you. Thank you, sir.